Okay. So good morning, everybody. Great to have a lot of you joining us on a Sunday morning. So quickly, just to, have a 2-minute sort of introduction of what the session is about. So Ushma and I kind of keep doing these things to, talk about some of the things that we as clinicians always feel like we wish there was a discussion on, these topics in a broader setting, right? I mean, you talk to a friend or you talk to a colleague, but that's usually one-on-one and you kind of are limited to that opinion or that viewpoint. So this was an effort, we started in COVID for that. Today's topic is prematurity because November is Prematurity Awareness Month. But we know here in India, we're going to be celebrating Diwali and, going on holidays and whatnot. So we decided to just do it today. Ushma, do you want to give your introduction a little bit and then I'll do mine?
No, I guess by now, at least the physio
Everyone knows. Yeah.
knows us. But I just wanted to say that, yeah, I'm from Bangalore. I work in Bangalore. Pooja is from Pune. And also the case populations that we see, I see largely 3+, and Pooja is in the NICU. So today we are going to hear all about NICU and young babies, from her. I just wanted to know so far the number of people who have logged in. Can you please write in the chat box your questions, as well as whether you are a parent or a therapist. Some of the therapists I already know, but I just want to make sure. Please write in the chat box. That would be helpful. So, I think we can jump right into the topic, Pooja. We can start.
Okay, great. All right. So, like Ushma said, I primarily work in a NICU. Just to sort of give the background of how that happened, because a lot of therapists I meet, will always ask me, how did you get into the NICU? So my background comes from being in the early intervention setup for many years. Some of it, or a large chunk of it, was in the US. And then coming back here to India, I just basically started talking to people. So initially, I wanted to just see what was happening because I was away for so long. But then, people are very interested in the concept of early intervention in the true sense, and a lot of the preventive stuff that, I was talking about. And so slowly, that's how I kind of, got attached to a couple of places where then, I did not jump into the NSU. I will say this, day one, even with, at that time, I think I had about 15 years of experience as a therapist, along with a lot of interaction in the NICU off and on in the US through courses and like hands-on training. And there was a person that I used to just go and like say, hey, can I spend the day with you in the NICU? Once in once in 4-5 months or something like that. So with that minimal sort of exposure, but even then I was not comfortable being in the NICU day one. And so what happened was I slowly got trained, I did a lot of courses, I, did a lot of observership. I found my mentors, and that is how I slowly now, got certified as well. So the first thing I would like to say to, people, especially therapists here, is that a lot of times I hear, oh, I'm a neonatal therapist or I'm in the NICU. But please remember, it is not translating what you know for a child. In like, it doesn't translate that, oh, this is a older child, so now this is a younger child, and so I'll just do little less. That is not how the NICU system works. Okay, so having said that, the majority of the infants that are in the NICU are preterm infants. Okay. So, like Ushma said, it would have been great to hear from people who are here today if they're a parent or a therapist. I have people put it in the chat. I don't see.
No, I don't. They've still not. Maybe.
How about this? Can
raising
you
hands? Just raise hand if you're a parent.
Yeah.
Raise hand if
How
you're
many
a parent.
parents do we have here? Can I quickly have this?
Okay, now people's reactions have started coming in. So I think,
Yeah.
no. Okay, great.
Any parent here at all? If you are, can you just maybe raise your hand?
Yeah, raise your hand
I'm
away.
assuming everyone else is a therapist.
Uh-huh.
Yeah.
Seems
Okay.
seems
like more therapists. All right.
seems like more therapists. Yeah. Half of them I know from Bangalore. So
Sure.
yeah, yeah.
Okay. So, all right. So, like I said, the majority of the infants that are in the NICU are preterm infants. And the trajectory that they sort of are on is so varied, not just for that person, but even or not just as a group. Like, a lot of people will say, oh, 33 weekers will have, or, between 32 and 34 weekers will have a certain trajectory, or, things like that. But I feel like even within the same infant, in the morning they present differently, and in the evening they present differently. So the first thing to remember is that your foundation of how development occurs, or how it is developing, because there's a difference between development occurring because of environment, and then what is the natural physiological, anatomical, neurological, development trajectory in itself. Like, what would have happened if this child was still in utero, right? So you need to have a good knowledge of that, and then understand what are the influences, additional influences that have now, been put upon this child, and how our role then is to, make sure that the effect of those influences, the negative effect, is reduced as much as possible. Okay. So basically, any child born before 37 weeks is called a preterm baby. The other critical thing we need to remember is that there is something called as the chronological age, and something called as the corrected or the adjusted age. How many people here are familiar with these concepts? You can just raise your hand.
You can go into that reaction thing and then raise your hand. I think that is what it would give you. Wave your hand. Yeah, raise your hand. Okay.
Awesome.
Correct. Yeah. Great. Corrected age and,
Just, yeah, chronological and, yeah, okay.
Yeah.
All right. So basically, chronological age is, the amount or the age from the time of birth. So if the baby is born at, say, 34 weeks and has been, out for, say, 2 weeks. So the baby's age is 2 weeks, right? But because they are preterm, what we do is we make sure that we correct their age for development purposes, right? So we need to make sure that what we are expecting of them is not too much, right? So what we do is we will say, okay, this baby is, chronologically maybe 2 weeks old, but they are adjusted age of 30. I forgot what I started with, 34 weeks.
36.
Yeah, so now they're 36 weeks. Okay. So, and it's a little more significant when it comes to them being in your outpatient setup, because you're going to run tests and you're going to run assessments, or you're going to talk to the parents about what they should be expecting. They're going to go home and start comparing their child to the neighbor's child or the people they see around in their family. And so if they're saying, well, this person is 6 months old and my child is also 6 months old, but they don't behave the same or they don't look the same, then you need to be aware of, this concept of corrected age, especially for development. Okay. Similarly, for growth, you cannot expect the baby to have a growth trajectory of a full-term baby. So if the baby was born at, say, 1.2 kilos at birth, generally what they say is you expect about a doubling of weight by 4 months, right? So if a baby who is born at 3.5 kilos at 4 months is going to be 6, 7, close to that. A baby born at 1.2 is not going to touch that no matter how well you feed the child. Okay, so they're going to look smaller, they're going to look tinier in that sense. So make sure that you understand these things when you're dealing with preterm infants who have now come to your outpatient setup. Okay. um, I will just, because we have new people joining in, I will just take a quick minute and say, please post your questions in the chat box so we can have a or more discussion based,
Yes.
interaction rather than me just
Mm-hmm.
talking about,
Mm-hmm.
all of these things. So please, we are very interested to know if you see, preterm babies early on, what is the age they are referred to you, or generally what are the concerns that are, referred to you, and so we can have a lovely chat about those things.
Just
Yeah.
one thing I would like to jump in with a number of points, but one point I would like to mention is that when you see these children born at preterm, when you see them at ages 3, 4, 5, in fact, I've been referred children who are even now 8 and 9, who have a history of preterm. So, number one, I wanted to clarify is, go into the history and see how preterm they were, how much intervention they have gotten, because some of them have not gotten an intervention. I have heard things like, the doctor has said, oh, the child was born at 36 weeks, meaning the child is full term. So by definition, okay, fine, I agree. But even at born at 36 weeks, a child has a lot of issue for various reasons. When they are 4, 5, you don't see the issues concretely till they are 4, 5. I've heard doctors say, oh, the child is only 4 weeks early, meaning 1 month early. So the child will only lag behind by 1 month. And then the parent has understood that the child will lag behind only by 1 month throughout their life. And then when the child is 1 or 2 years, it has come as a shock to them that, the child has had delayed milestones. So there are a number of things to consider when such children are born. Children are born premature or preterm, to consider when they are 3, 4, 5, 6 and above. I'm not saying necessarily, but most likely these children are likely to have issues that may be missed out later. So I can talk about it later if we have time, but right now I will let Pooja speak. And please type your questions in the chat box that you have for her, because there's a lot you can learn from Pooja.
Yeah.
Pooja.
Okay, so let's quickly just review the role of a therapist in the NICU. Okay. A lot of times, again, see, our field is still new in that sense, right? I mean, therapists being in the NICU, a lot of times it is mostly a referral. A doctor will call and say, oh, come and see this baby. And so if you have not really seen a variety in the NICU, then we are also struggling to figure out how to help, each family. And you can help each family. Okay. It is very, very, very individualized in the NICU. So I won't, obviously, this is not the platform to go into a lot of detail, but just to give an overview, is that I see primarily, if you're a new therapist stepping in, then there are three things I think that you should absolutely get a good grip on. First of which is nesting or positioning. Okay. Uh, an infant who is born preterm, A, and B, a infant who is unable to have any, or who does not have motor control to work against gravity. Okay. If you have just placed them in the bed for a prolonged time, they are just going to have a bad posture, because, okay, that's what I was trying to say earlier, is that think of this as a, I guess there are a lot of women here, so I can take this example. Think of you needing a dough. Okay. So the preterm phase is that kneading of the dough phase. Okay. So if you have a half done dough, right, and now you are trying to sort of, I don't know, use a fork or a spoon to now mix it up, it is not going to shape in the manner that you would expect, if you had finished the process and then done something, like a mistake, like added extra water or something to it. Okay, there's a difference. And so while this baby is developing, like I said, they have not had that much, or they have not had, they don't have the components to move their body well enough, right? Plus, there is now gravity acting on it. So if you laid a full-term baby, because you will see some full-term babies also in the NICU, say with a HIE or um, seizures or something like even sometimes a metabolic condition or a genetic condition that lands them up in the NICU. But you see the posture of that baby will have a lot better movements and ability to sort of work against gravity in spite of all of their limitations than a preterm baby. Okay. So the first thing the therapist, I think, has to be very strongly, like, what do you say, competent at is nesting. Okay. Uh, in nesting, again, we use multiple positions. We use supine, we use sideline, we use prone. Now, prone is something that is very much, what do you say, people are just scared about it for some reason, right? And so, again, the therapist's job is to step in there and say, all right, how do we do this safely? How do we do this so that, they're maybe, if they're intubated, especially, their tubes don't, like, they don't extubate, or, if they have a lot of the, um, like an umbilical line or something, how that umbilical line will not come off, because they are in prone. So you have to be very cognizant of these medical issues as well while you're positioning the child. Okay. uh, and lastly, about positioning is, a lot of times you will see that they will have a bed sheet roll around the infant, but please remember that if the roll, so if the baby is here and the roll is here and there is no contact, then it is not really helping the posture. The point of nesting is to help the posture. Okay. And there are a lot of, there are three tools out there which are very easy to use. One is called the iPad, which is the infant positioning assessment tool, which has, lovely images as well that says the head should be like this, the neck should be like this, shoulders should be like that. So it's a scoring tool as well. So it gives you various options. A similar thing with an additional of the trunk, section involved in it is called the NeoPaw, which is the neonatal positioning assessment worksheet. And then Dandelion has another one, which is called the NeoNap. It actually has a little better way of looking at positioning, because it's not just the way the nest is or the body is, but it also looks at containment, which is what the final stage of nesting or positioning is. Okay. So that's one thing in the bed. But positioning is also something that you have to look at while the baby is being held, either by the nurse for feeding, by the mother for KMC, or parent, I should say, not just the mother, but parent, because fathers are also welcome for kangaroo mother care, right? So the parent for kangaroo mother care, the mother for breastfeeding or vati chamcha. When we start in India, we are very, at least in the hospitals that I've been a part of so far, bottles are sort of the last resort, right? If we have tried and failed at every possible way to get this child to feed, then we would introduce a bottle. But we generally have vati chamcha or the palade, those little cup with the spout
Out.
in front of it. So positioning for that, positioning for interaction. How are you going to interact with this child, right? So all of these things comes under positioning. Okay. And lastly, for reducing the harmful or the negative effects of the environment. So what do I mean by that? If they're getting a procedure done, right? Um, so I was just reading about this the other day, that a lot of times, so we all know about, like, heel pricks, right? They take a heel prick for blood draws, or they'll have actual blood draws as well. But also, a lot of times mothers will wake up the baby to feed by flicking the sole of the foot, right? And we all know that that is a painful stimulus. It is not a pleasant stimulus. So all of these things that are part of the environment of the NICU, which unfortunately we cannot stop because we have to keep the baby healthy, right? You cannot stop the blood draws, you cannot stop the, medical procedures that are involved with, taking care of the child. But during that time, what we call as facilitated tuck, okay, or two-person care, um, or clustering of care, that is something that a therapist will get involved with, because the nurses, they cannot have four nurses helping one baby. We are already struggling in terms of staffing, unfortunately. A lot of cases that, again, I talk to or deal with, we are all struggling with nursing, good competent nursing in the NICUs. And so that's where I step in a lot. I'll say, okay, here, I'm here today, this baby is going to get two procedures done, let me do a facilitated talk, or just do a lot of sort of soothing prior to the procedure, so that the baby can regulate themselves through that painful experience. Okay. All right. So that was first. Nesting, handling, positioning, whatever you call it. So the gross motor posture. The second thing I think a therapist in the NICU absolutely needs to be confidently and competent about is feeding. Okay. Unfortunately, again, as physiotherapists, we do not have any exposure to feeding until you land up in the NICU. Okay. Now, I had a little bit of exposure to that because of my journey as a parent. And I realized how much like nuance there is about feeding, that, and especially, like I said, if you're working with a preterm infant, they already don't know what's happening, or they've not even had an experience of it. And now you are trying to tell them to do something in a very stressful and, environment. And so feeding is something that takes time, because we have to start from scratch. But that is something that you need to be competent in. There are, again, a lot of, workshops or techniques, or, things out there that you can, learn from. One of the simplest things is the PIOMI, which is the premature infant oromotor intervention, PIOMI. Okay. And that basically gives you a good oromotor stimulation technique. Some of those components are also what you use for checking if the infant is ready for feeding. So again, there are tools like the POFRAS, which is a readiness assessment tool. So to check if the baby is ready to, have oral feeds at all, because again, you don't want this child to aspirate. You don't want this child to have an bad experience of oral feeds, because even if it takes a little longer to get them to oral feeds or full oral feeds, at this point of time, it is better than them having such a bad experience of feeding that their entire life they will struggle with food. Okay. Not just eating, but just struggle with food throughout their life. Okay. Okay, so that was feeding. And the third thing is parent interaction. Again, it is unbelievable how much we are not trained to talk to parents, especially in a situation like the NICU, where, first of all, just having a preterm birth is so traumatic, right? No one expects that. When someone is pregnant, there's always this joyful sort of environment around them. There's always this happy anticipation that, oh, the baby's coming, we'll do this, we'll do that, blah, blah, blah. Clothes shopping or names, there's so much of like happy anticipation around it. And so if you have a preterm birth, just even the 2 or 3 days leading up to that, the mother is so much under stress because she knows something is going wrong, and the delivery might have been a painful process in itself. And the moment the baby is born, they are out of the, womb and taken straight to the NICU, right? So there is so much of like that natural attachment that happens in a birth, where the mother is handed the baby, the mother is allowed to spend time with the baby, breastfeeding maybe, is initiated in the first hour itself. The nurses are not so hands-on. They allow the family to sort of then step in and, take care of the baby after that first 2 or 3 hours where they've monitored the child, made sure everything is fine. It's all you. And so that is what the experience is of the family as well. And now no one has seen this child. They're in the NICU. The NICU environment is, because it's such an intense environment, everyone cannot go in. And if you have to go in, you have to like scrub yourself, you have to mask and a cap and gown and all of these things. And so the entire thing is very scary. Okay. Very honestly, it's just so scary. And then to see your child, because what have you seen of babies? Even if it is your first baby, you have seen these cute, healthy, bubbly, smiling, cheerful babies in media, in wherever, and now to see this infant who's, say, like I said, 1 kilo, 1.2, 1.5, their skin is all wrinkled, they don't have enough fat under their, in their body to give you that nice baby shape, you know, their head is bigger, their abdomen is bigger, they're like, like I sometimes call them snowmen, they're like that. There's like blob of the torso, blob of the head, the arms and legs are like these sticks, and they're struggling to breathe. They have maybe a lot of, if they're intubated, they have, wires and tubes, and, it's not a pleasant sight. It's not a pleasant sight at all. So even if you do take the parent in, then the next step, will this baby survive? Forget, when can I take this child home? Is this baby going to survive? Right? And so our communication, and again, we have a good role right from day one in this whole process. Okay. Like I said, just getting the mother to come and touch the baby if they cannot be in a kangaroo mother situation, just having them come in and do like a loving touch is something that a therapist can lead. And so you will not just say, okay, come, we'll do this. This mother needs to have some coaching, some hand holding, not only for the physical like process of it, but the emotional process of it, and so the third most important thing as a NICU therapist, I feel we should, even if you're thinking about it, or even if you're in a hospital that has an NICU and they're referring, one or two babies to you, start thinking of these things. How are you talking to the parent? Okay. And not just for today, but sort of giving them that, picture for the next 2 or 3 days, or, like Ushma just said, that someone will say something like, oh, 1 month gap, but that 1 month gap is today. How does that change over time, and what can they do to make sure that that doesn't get wider and wider as time goes on, um, I will quickly end with saying one thing is that, or rather two things. Okay. One is that the mother unfortunately becomes this person that, positive and negative, okay, everything is always mother. Okay. Baby did this, mama, today baby did this, or, oh, baby's not doing this today, or like, there's a gap, or whatever. It's always the mother who's at the center of that information processing. The father's there. No, I'm not saying that they are not, but the way the mother processes that, it becomes very personal to her. Okay. For example, I must have done something, which is why the baby was born preterm. My body couldn't carry, this child to term. Like my body is not capable of it. Feeding, right? So again, if the child is in the NICU, you don't have any physical closeness, the baby is not sucking, your milk supply is in a lot of trouble. So how do you keep that up? There's a lot of work that the mother has to do to make sure her milk supply doesn't go down while the baby is in the NICU, right? And so fathers, no matter how caring and supportive and involved they are, there is a lot of burden on the mother. Okay. So please make sure when you are, again, counseling, talking, whatever it is, that you, like, your voice is neutral. She's already getting a lot from her family members, her internal, voice. So that's one. The other thing I wanted to say, which I just blanked out on. Sorry. I had a very lovely thought and I just like disappeared from my mind right now. Uh, anyway, I'm sure it'll come back to me. I'm sure through the,
So basically, you're talking
yeah,
about communication. We have to be
communication.
watchful
Yes.
for communication, actually for all the parents, but this newborn, preterm, in the NICU or with medical issues,
Yeah.
I guess we really have to be much more sensitive. But that is a very good point. I sort of, it was like a light bulb to me, Pooja, when you said that the experience of feeding, the first experiences of feeding, they may even relate to later experiences in early childhood or, throughout childhood. And now that I'm thinking the children who come to me at 3 and 4, obviously they do have feeding issues due to oral motor sensitivities, etc., right from early childhood. But how much of it is also related to the feeding done by the nurses or the parent right in the NICU or during newborn? I would now start thinking about that. So thank you for that. Thank you for that. So we have one question, Pooja, about the PYOME.
Yes.
Is PYOME a trained program? Can you brief about this? And
Yeah.
then the other question is like 31 weeks. Somebody has said 31 weeks, meaning I don't know what they mean. The therapist or the person who's written 31 weeks. If
Oh,
you
I
have a
know. No,
question.
I know what she's saying. It is the
Uh-huh.
adjusted age. It
Okay.
was not ahead. You have to go
Okay.
back.
Okay. Okay.
Yeah. Uh, I knew I was making a goof up.
Okay. Okay.
After so many, I have to admit,
After so
after
many
so
years, yes,
many
it is.
years
It
as
is
well,
confusing. It is confusing.
not
Yes.
confusing, but I still have to write it down. Like I
Yes.
always write it down because I
Correct.
always end up like getting so mixed up with and so now we were just saying weeks, right? But there is also days. So
Yes.
31 weeks, 2 days, 31 weeks, 4 days.
4 days. Correct.
Yeah. So I always end up just, writing.
Yes.
In my notes, you will always find a little like math, like how rough work we used to do in
Yes.
school.
Yes. Yes.
Yeah.
Good. So PYOME being a trained program, you can
PYOME, yes.
brief a little bit about somebody has.
Before I talk about PYOME, I just want to, address what you just said, Ushma, about the process of feeding or the experience of feeding. So basically, the reason or and not the reason, but the most common, this is that the baby has to learn how to coordinate their suck and swallow with
Yes.
breathing,
Yes.
right? And so if that is not happening correctly while that development is occurring, your brain is always wired to say, anytime there is food or there is this thing, I'm going to struggle with breathing. Like
Yes.
it is starting to go together hand in
Yes.
hand.
Yes.
And so that's where, again, the positioning is very important for that. How you position the baby while you're doing oral feeds is very critical.
Yeah.
Okay.
So basically, for therapists, it's very important to remember throughout life, or at least in childhood, what we say, what fires together, wires together. Always remember that fires together, wires together. Means in this case, if the feeding is a stressful, experience for the baby, then the feeding, the parts of the brain, the oral motor areas, and everything, the sucking, swallowing, etc., everything, the parts of the brain that are responsible for that, then get wired together with the emotional, that, oh, I'm going to struggle, or this is not pleasant, or, so that is where I mean, fires together, wires together. Okay.
And then I just remembered what I was going to say about communication as well. Is that knowledge does not always mean action.
Yes.
Okay. A lot of therapists will come and say, we've told them so many times. You've told the parents so many times. They just don't do it. Okay. Now, I want all of you here to think of what you know and what you actually do in your day-to-day life,
Mhm.
right? There is no connection between knowledge and action. I mean, I wouldn't say no
But
connection,
poor
but
connection.
it's hard sometimes to translate that into action if there are barriers like anxiety, stress, low confidence. Who is teaching this mother to hold a infant who is so tiny with so many wires, hanging off to get that baby positioned on the breast? Again, if you are in the NIC, you will see what the nurses do is, okay, chalo, chalo, mother, come for breastfeeding. You sit down, the nurse picks up the child and hands over the baby. Okay. So all this mother is doing, like just sitting like this, right? And she's just inserting her breast into the child's mouth. So if you have never handled picking up, an infant, understanding, okay, how do I wrap the baby so that their arms are not falling off, things like that, the mother has not developed that confidence. And same happens with the fathers, I have to say. Okay, when I talk even full term babies, I mean not, full term typical babies, fathers are never allowed to do these things physically hands on, and so there is a feeling of low confidence, you know and so all you need to do is just do it 10 times, do it under supervision, you will get it. Okay, so please be very empathetic towards this thing of knowledge always does not mean action. Even if you've told them 20 times, you still might have to work with them hands on. Okay. Pyomi. All right, I'll go to Pyomi. Pyomi is, yes, there is a training program that is associated with it. It is now available online as well. It's very easy to get through it. It is basically what do you call it? A protocol. There are say 8 steps that you follow in a certain sequence. And so the training has all of that. Included, like how do you go through each step and what do you look for, and the training is very well done. So yeah, it is. You know, it's a good thing to have in your toolkit, especially if you are attempting feeding in the NICU. Okay. All
So
right.
can you tell them quickly, Pooja, as to how do they find Pyomi? Do they just type the
Oh,
word, type the
yes,
abbreviation, and they get the
Pyomi.com, I
information,
think. Yes,
pyomi.com or something?
yes.
Great. Okay.
I can look it up in a minute and put it on the chat as well. But it's very
Yeah,
like
we
it's
can put it up if all of you are there. I hope all of you are there in that Let's Talk Pediatric PT group. If you are not there, please join it. Message me how to join it. We can share the link over there also later if you need to. Okay. Hmm. So Pooja, we have the next
yeah.
question is, till what age there is a difference in the expected development? I mean, when do the preterm babies streamline in the development like a normal full-term baby? Even I know this is a complex question, but you can
Yeah.
you can answer better on that.
So I will say I don't know, very honestly.
Yes, I
But
would
what
say the same.
happens, yeah, what happens is we stop adjusting their age at 2 years. When they turn 2 years, we stop adjusting their age. I think maybe in the 70s or early 80s, there were a couple of studies done where they had a long-term follow-up of babies, and they found that by 2 years, they catch up, you know. Having said that, again, if you have started from a place where, uh, the, I don't know, the function is not great, right? There is always going to be some limitation that you will see. Okay. I'm sure you all know the GMFCS levels, right?
Mhm.
And so I mean, of course, we are not grading a preterm infant or even a 1 year old on that scale, but I'm sure you all know that a 4 is not going to turn into a 1 no matter how much therapy you do, you know. At the most, they will jump one up or down,
Mhm.
but you're not going to have that much of change through therapy.
Covering the gap. So yeah,
Yes.
GMFCS generally, if you're familiar with the levels, then if you have good therapy, good intervention, if parents follow up, then the child is highly likely to change the levels of GMFC, meaning rise by one level, the GMFCS. Beyond that, it is questionable. But when you said streamline in the development like a normal full-term baby, it all depends on, what they were born with, low muscle tone, high muscle tone. It depends on the cognition of the child. Again, then the cognition depends on the early stimulation, because nowadays I find that, as I said, doctors have said that, oh, don't worry, everything is fine with the child, or the child will catch up, your child is only 1 month lagging, they will catch up. So these are the things I hear. I hear doctors saying, oh, when the child is 5, everything will be fine. So what has happened is, when the parents have not only access professional help, and these are the middle class parents or even the upper middle class parents I'm talking about. I'm not even talking about the lower economic classes in our country, where again it's a different story. But these are the parents have absolutely believed the doctor. They waited till like 5, 6, 4, and then when they've seen concrete issues like speech is much more behind, the child's weight gain is very, very poor, the child is balancing, I mean, the child is walking, oh, so for a parent, a child walking is very good, if the child has even walked at 2 or 2.5, that is great. But then walking is not everything, right? So now the child is, balancing is like this, so then they are not able to write in school, they are not able to have social interactions, they are not able to make friends, following commands, I mean, many issues. And they've told me that we were told that everything will be fine at 5. So when do they catch up is depends on a lot of sensory, motor, cognition, emotional areas, and that early stimulation. So early intervention, we had a discussion in that Let's Talk Pediatric group, where early intervention is misunderstood in our country. Early intervention means 0 to 3 years, and early intervention is transdisciplinary in the sense whether you are a PT or an OT or a speech therapist, any one of these works with the child and basically addresses all the needs of the child, and teaches the parent how to interact with the child, how to play with the child, positioning, feeding, etc. Our country, it is a little bit misunderstood. We had that topic discussion in the Let's Talk Pediatric PT WhatsApp group. So and then the parents have never made any attempts to really play with the child, or on the other hand, they protected the child a lot because, oh, now my child is walking, but he was born at 32 weeks, has a significant medical history. So then they've overprotected the child. Again, that we all know what overprotection means in later sensory motor development. So there are a lot of points to consider in all of these, as to when do they catch up with development. Okay.
Right.
We have one more question, Pooja, is that
Yes.
is spoon feeding preferred for preterm babies over bottle feeding?
Very good question. Because to be honest, if you look at all the literature and a lot of the trainings out there on feeding in preterm infants, they all have a huge focus on bottles. Okay. I think couple of things. One is that we don't have the variety of feeding options with the bottle. Like for example, there are a lot of the nipples that you use on the bottle, right? There's a lot of variety in that, which that's called the like flow rates basically. So how much milk kind of drops from the nipple, because it's a passive feeding, right? If you tilt the bottle, the milk will start dropping down. So what they do is it depends on how you have, like the way you hold the baby and the bottle, and how you actively get them to engage with the feeding with the bottle, is something that is a focus of a lot of preterm feeding literature. Okay.
Mm-hmm.
Two things. I think one, we don't have those many feeding nipple options in India. So, we are very short in that sense of moving from a slow flow rate to a high flow rate, which again, if it is a high flow rate for a child who's not capable of it, the experience of feeding, if you're messing that up, you're going to land up in bigger trouble later. The other thing is we have mothers. We have access to mothers. A lot of these Western countries, their mothers are not there 24/7 with the infants in the NICU. We have mothers just, in the hospital. They have beds given, they are, there. And so why wouldn't we try the breastfeeding directly, right? In that sense, as compared to bottles. So that is the other cultural aspect of why breastfeeding is emphasized. And then if your aim is to breastfeed, bottles do interfere with that. Bottle
Yeah.
feeding, the mechanics of bottle feeding are way different than what is required for breastfeeding. And so initially what people do, which again, now as have gotten better trained with these things, I realized that I could do um, breastfeeding much earlier than what, is the norm here. So generally what they do is when you have to start oral feed, they will start with the vati chamcha, see how much the baby can tolerate, before they start showing stress signs. So if the baby is supposed to get, say, 20 ml or 25 ml per feed, they are not going to go to direct 25 ml orally day one. So they'll start with, say, 5 ml, 7 ml, 10 ml, 12 at the most, right? 12 is, I mean, half is generally what I've seen day one they can handle. But that's one feed, and you have to feed, say, 8 to 10 times depending on, what the interval is. So they are not going to go to all oral feeds day one. So they'll do, say, 2 oral feeds. Then they will say, okay, the baby handled it well. Tomorrow we'll do 4 oral feeds at 50%, so on and so forth. So there's a process of how the, feeding sort of progresses. And so generally what we do is, like I said, we start with the vati chamcha. If the baby has not, really shown any signs of stress, and handle the feeding well, uh, a lot of times either before or simultaneously, we also start what we call as non-nutritive sucking on the breast. And if the baby is doing both of these things fine, then we can move directly to, one oral feed directly on the breast, you know. So for this process, the bottle sort of interferes with the mechanics of that learning, And so, yes, long story short, bottles, are my last sort of choice. If I didn't have the mothers, if I didn't have them come in, and all of those things, then yes, because we need the baby to survive. So if someone has used bottles, if there's a mother here and you have used bottles, I will say I have used bottles too for my child. Uh,
I
but
have two. Yeah, I have
yeah,
two. It's not an
exactly.
absolutely black and white option. Black and white solutions. As I say, in
Yeah,
therapy, there is no black and white solution. So if
exactly.
you're a therapist,
Exactly.
please don't look at yes or no black and white solutions. Ever, ever. But the breast is on, or the vati chamcha is the Marathi word, meaning katori and a chamcha.
Oh yeah, sorry.
Uh, katori and a chamcha. They are always better. They're more hygienic. And a lot of this bottle feeding literature, what Pooja says, we don't have enough, or we have it because it emphasizes on bottle feeding is because it comes from the West. We are a different culture. Please understand that. Okay, we are a different culture, even now, even in modern India. So please understand that. Okay. Yes. Hmm. There
Oh
is
yeah,
that
you put
link
up
link
the
to
link.
Pyomi. Yeah,
Mm.
I've put up the link to the WhatsApp group, and there is also a link to the I think Pooja has put it in the chat box. The link to the
Pyomi.
Pyomi training. I hope all of you can see that. If you cannot see, then please let me know. So anything else? Anybody has any questions to jump in, or Pooja, do you have to, do you need to share, anything else?
I think I'm good. I wanted to just, give sort of highlights of what therapists can do in the NICU. I think we've already done a couple of talks on tummy time and the early
Yes,
intervention things.
tummy time. If
You
you
know,
don't know what tummy time is, or if you want to watch more, then please go. At least I run this YouTube channel. If you don't have access to it, please ask me, or, there we have done tummy time, I think 2 years ago.
yeah.
So tummy time also, please stress on it. If you're working with younger babies, or even if you're working with older children, please stress on, doing activities in prone, whether you're doing it on a swing or a floor or a bolster, etc. Please stress on prone. Prone position, again, if you can't start with absolute prone, because I have 4 and 5-year-olds also who just don't like the prone position. They've never been on it. So then you have to start with the modified prone, first minimal prone, whatever you call, please start gradually. And what I wanted to say is, yes, I see a lot of children who, I have a 9-year-old right now who was born at 28 weeks, never got early intervention, everything was fine, now has landed up with me with handwriting and attention issues, although he's making good progress there within 6 months. But what bothers me is a lot of impulsivity, like no safety awareness at all. So that is one thing. I have, many children born at 32 weeks, 33 weeks, who do have speech issues, feeding issues, feeding meaning, they will not eat, they will only eat 2 or 3 kinds of food, and then we are in trouble. One more thing I would say, by definition, we say 36 weeks is a full-term baby or whatever you call. However, at 36 weeks, just understand that at 36 weeks, the child has, almost grown, and they have less room in the mother's womb, So that is when they have less room to move around in the mother's womb. So what they try to do is, the babies at 36 weeks try to start pushing against the uterine walls. Okay. And that is when the proprioceptive system starts kicking in. So if a child is born before 36 weeks, I see a lot of proprioceptive issues. All right. These are small things that I wanted to share from my clinical experience. And yes, it is mentioned in the therapy literature here and there, or from senior therapists. I've also learned from senior therapists. But yes, if you see some proprioceptive issues, go back into the history, most likely the child will be born before 36. Or then again, when I say, even my own children have been born at 30, 37, 39 and 38 weeks. However, what happened is, I somehow gave them a lot of physical activity, prone on tummy time and crawling, and even crawling up the stairs and things like that. Today, what we have is that kind of physical work is not done by most children, floor time and crawling and things like that. So I'm not saying that if a child is born at 36 weeks, they will never have the proprioception. No, they will catch up, or they will not have proprioceptive issues if they've gone through the natural development, where the child is on the floor and crawling and tummy time, etc. But even if that has been missed out, or they have been overprotected, then they are likely to have proprioceptive issues. Okay. Yes, somebody was trying to come in. I think you can unmute your mic and come in. That's fine. You can unmute your mic and come in if you have questions. Anybody?
How many of you are working with, say, younger babies, less than 1 year old?
Less than 1 year old?
Oh, nice.
Oh, nice. Indira
early intervention.
And that's why she asked, I think she's the one who asked the PYOME training. So good. You got some information, Indira? Good. Okay. Do we have any more questions? Children born, premature or preterm or whatever you call it, also are highly likely, as I said again, to have issues with executive functioning later in life. So please keep that in mind at the background of your history taking or assessment when you see any child, because then this child will come to you at 7, 8, 9, 6, whatever. They are highly likely to have issues, executive functions. So the higher functions that we call, and then executive functions keep on developing till age 80, actually, till our frontal lobe development is complete. So when they don't have executive functions, so what are executive functions? Problem solving, planning, what is next, timing, sequencing. There are many executive functions, following more than 2-step commands. There are many executive functions that are a part of a young child. But, I do see that many of the children who are born preterm are highly likely to have these executive functions. And then they are highly likely to have then, issues with academics, particularly maths and language. So therapists here who work with older children also, it is helpful to keep this in mind.